Okay, gravy. So it's lovely to have everybody again this evening. Um, we are doing it a little bit differently this week due to all sorts of people being on call, coming off nights, long days. Charlotte has even come when she's ill herself to be here to teach today. We're going to have myself and Mozhy run through some pediatric stations for you. We've tried to keep them in line with what's come from Manchester in the past few years, high yield content that'll be useful for any university as well. And there's plenty of practice in there, so it shouldn't make too much of a difference. Having me here, a fellow final year, instead of an F1 facilitating this session. But we've got Mozhy and Charlotte as always, who'll be there to give you guys feedback and make sure that everything we're saying is correct. So thank you for joining us. Next slide, please, Mozhy. Just a disclaimer that we always do as Manchester MedEd, this doesn't supplement any of your university materials. Please continue to engage with your courses as usual. We're not here to supplement any teaching. And this is the kind of timings we want to work towards today. So we're starting at 5 past as always. We've come up with a couple of different history taking stations. We'll go through one as a group first, and then there's 2 practice stations to do in rooms. Then I'll take you through examinations, but the key thing being what's the difference between kids and adults, because otherwise you can just go and look through your examination books that you've learned at uni. And then we'll have a little break. And then when we come back, Moshy's got lots of stations for you to practice as well. So we'll be doing more practice stations than we usually do this week. We'll be doing 6 instead of our usual 5, so we'll be quite militant on timings. Next slide, please, Moshy. So when it comes to history taking in pediatrics, I think there's a lot of jokes made that, parents are over worried and the first thing we should jump to is the reassurance. But when it comes to us, particularly as residents and juniors without that experience, we meet children and their parents at the point of the presenting complaint. But if you click again, Mozhy, before all of that, there was an early development period during the pregnancy. There was their early years development before you've even met them, and they're going to have presented to the GP or secondary care, emergency care, we don't know, multiple times before that. So it's really important whenever you get a child presenting to place them in a greater context because they can't advocate for themselves. The only person who's been there for all of that is going to be the parents. So if you click again, Mozhy. This is you taking their history, but this is where the parent and carer comes in. So you need to ice and consider what they think might be going on just as much as ever, if not more, because they know their child the best and they know when something is notably different in their behaviour and general demeanour and health. So that's the general gist for history taking in paediatrics. So sorry the animations have gone weird. If you just click through all of them, Mozhy. There's a bit of a sort of tick list you can take yourself through. So the nice thing with paediatrics at this stage is it's very systems based. So if they're coming in with shortness of breath, you can take a nice focused respiratory history just as you would in adults. But the main difference is there's some key indicators a child's unwell that is very different to adults. So concerning features differ slightly. The big ones are they having normal feeds? Are they having the same number of bottles if they're a baby? Are they still eating and drinking as much if they're a bit older? Are their toileting habits the same? So is their urine output the same? Are they still passing normal stools? Any bleeding from anywhere? And then do they have noticeable increased work of breathing? So any recessions, and we'll talk through those a bit more in the RESP exam, projectile vomiting, changes in their movements. These are quite PED specific. And then this is just a little guide of the questions you can ask to build that greater context around the child so that you can understand a bit more why they might be presenting this way and sort of problem solve of what might be the issue going on. Next one, please. So this is the first example we're going to work through as a group. It's quite classic of a paediatrics OSCE. I thought a good history to just have a practice of taking. And the main point of us going through it is to just review the red flags of vomiting in a child. So first thing, we've got a mum's brought in her 3-week-old and she's worried about her continuing to vomit. Where would you start? People want to answer in chat just to make it nice and engaging with everybody. in the chat. Maybe I'm slow. Yeah, so Socrates of the vomit, timing, bilious, non-bilious. Yeah, any head injury? Good point. Have they fallen at all? Get that out of the way quickly. Yeah, any concerns with the pregnancy? As we're still quite early days. Yeah, weight loss. We'll come back to weight loss. Any more for any more? Feeding concerns, how much and how often? Yeah, how are they feeding? Abdominal pain, failure to thrive, stools. Yeah. If you want to click through, Molly. Molly. Only been 5 years. Yeah, so she's been vomiting consistently after her feeds. So if you click again, she's exclusively breastfed. She brings up clear milky vomit every time. And just after feeding, she becomes quite grumpy and starts sort of wriggling in her mum's arms like she's trying to get her back arched. When her mum's looked, she's not noticed that there's any changes to her skin. It's not like she's trying to constantly itch down her arms or her tummy. She's become quite reluctant to feed though recently. She's still feeding eventually, but is resisting a lot more. But wet nappies are normal, and in her nappies, stool looks normal as well. Not seeing any new like mucus or any changes there. Birth-wise, had a normal vaginal delivery. All the scans were normal, no worries about growth. And yeah, born at 38 and 2, no complications. So next part, please, Mozhy. Just finishing off the history. Early development wise, started at 2.4 kilograms, and now at 3 weeks old, she weighs 3.2 kilograms. So my first question is, how is that in terms of weights? Just by pure numbers. We don't have a chart. She's only 3 weeks old. It's me being a bit mean. Because somebody mentioned weight loss. Yeah, so it's good. So in the first sort of days, first week, you can lose about 5 to 10% of your weight. And then by 2 weeks, you expect to have caught up again. And then this kind of weight gain in that time, I think it's something like, is it 400 grams a week, 450 grams a week? That's what you expect in the first 3 weeks. So this weight gain is fine. Calmed by mum's voice, able to follow a toy, so milestones for 3 weeks are fine. And this is their first baby. No smoking, no alcohol in the household. So next slide, please, Mozhy. Oh, yeah, she's not got past medical history. She's 3 weeks old. Differential diagnoses. Oh, if you go back. Not that yet. Thank you. It's a surprise.
Sorry.
Yeah, so it was clear milky vomit. Real. Okay, so we've got some good differentials in the chat. If you can click forwards, Mozhy. So our most likely differential in this case is gastroesophageal reflux disease. And in children, this is just due to the immaturity of their esophageal sphincter. So the main difference is you can just have a child with reflux, but the fact that this child's wriggling around and seeming a bit reluctant to feed, they're still feeding, but they're associating their feed with pain. That suggests it's a GORD rather than just a benign reflux. So that's when you make your decision of, okay, we need to give some counselling here. And we'll think about next steps in a moment. But in terms of vomiting in children, there are some key red flags to think of. So I've separated differentials into medical and surgical. If people attended the paediatric surgery talk I gave a few months ago now, they'll recognise these two lists. But in terms of history taking for OSCEs, where are the red flags in this list? What are the key ones you need to rule out in an OSCE? Yeah, bilious vomiting. Yep, suggestive of an obstruction. For example, if they were like trisomy 21 baby, they might have like a atresia. Yeah, masses is one to rule out. It's mum's first baby though. She might not have known the first thing to do is to feel baby's tummy and feel for masses. That would be a red flag for us to maybe look for on exam. But in terms of actual history, yeah, projectile vomit, fever, neurological signs, fab. If you click forward, Mozhy, please. So, sounds obvious, but it's actually not that obvious when you're taking a history. Look for signs that they're dehydrated. Children are quite sensitive to fluids. So look at, have they got like sunken eyes? Is their skin turgor really gone? Those might be things that mum has noticed. Like she's not looking as red as she was before. Bloody stools and vomiting. Worry about that as well, but 3 weeks old. You might expect it to be a little bit later, but you never know. And then if you click again, Mozhy. So these are the key ones, which you all very rightly said in the chat, that are the main red flags. Don't forget whooping cough, post-tussive vomiting. That is also a red flag and a notifiable. I'm pretty sure border pertussis is notifiable. But yeah, projectile bilious association with neurological symptoms. Worry about stenosis, which needs surgical referral, obstruction, which again, surgical referral, and possible oncology referral. So that was just the main learning point from doing that history together. So in that regard, if you click again, please, Mozhy. What would be your next steps? Someone started mentioning it. We've taken a history for right now, and we've not got any red flags in it. Our top differential's gored, but what would we do next? We'll just talk through this one. I'm afraid I have no fancy slide. Yeah, so start off with an examination of baby. Have a look at their tummy, feel their tummy. How are they responsive to the general appointment, responsive to their mum? Okay. And then anything else we might want to do? Yeah, signs of dehydration, observations. Cool. We'd use the pews at that time. Yeah, head to toe exam. Baby's still quite young, not so far post 9P exam. Yep, get a plot of growth chart because we think it's a gourd right now. We don't know if there's any other underlying issue, if they'll start dropping off in terms of their milestones. Brill. Yeah, that's all sensible. What would you advise, Mum? Does you have to send her away with something? We might not necessarily jump straight to medication. Yeah, feeding technique. So helping her understand that you shouldn't have baby too flat when she's breastfeeding. She's exclusively breastfed. Yeah, sit up post feeding, but also do small, infrequent feeds. Could have put it into the group history bit, but imagine this baby's feeding like 3-4 times a day and is having a big feed every time, and then they're vomiting afterwards. It's not obvious. Like you need to help her. She's a new mum, and these things are what we're there for to help them with. So yeah, that was just that history. But what we're going to do now is send you guys into breakout rooms. So your first scenario is going to be a 6-year-old with a new rash. Dad's brought her in, he's worried about the rash. And then second scenario, I will send in about 8 minutes time. Okay, so if we start off with, we were on scenario 1, which was child with a rash. Uh-oh. Spoilers.
Sorry.
Okay, so first of all, how do people find the history in the chat? Or if you just put a little react. And then if people want to put some possible differentials as well. I thought rash was quite a good one because the differential list is quite broad and your questioning is really important on it. Okay, we've got thumbs up, that's good. If you want to flick to the next slide, Mozhy, I promise it's safe to do so. So yeah, my daughter's come out in this new rash. What kind of questions are people asking? What are we going? Was all right. Nice. Okay. So in terms of rash, yes, Socrates the rash. where is the rash? When did it start? How does it look / feel? Do you feel like it's moved anywhere? What other symptoms has your child had recently? Like, are they generally unwell? Is it an itchy rash? Is it a bleeding rash? What's going on with the rest of the face? Have they got any involvement of the mucosa of the eyes, of the mouth? Really get into the nitty-gritty of where this rash is spreading. Yeah, neck stiffness, photophobia. And timeline, has the rash evolved over time? Did it start off one way and then it's got different now? Is it exacerbated by something, like if you used a new bath salt and they've come out in this rash? And how bad is it? How much is it affecting the child? So in this case, you should have elicited that this was, I don't have this on slides, I'm sorry guys, that first noticed this rash on their son's tummy, on daughter's tummy even. It says his tummy, but it should be her tummy. And they can't say fully where it's come from, but she's not really been herself for about a week. So 4 days before the rash, she wasn't really herself. If you directly asked, you should have been given the information that she has some new spots, some sort of grayish spots in her mouth, but tongue is as normal. She was more sort of coughy, coldy than having a sore throat, and she won't stop itching her eyes, and sometimes they seem a bit leaky. Fever's really high. Started off as a sort of dotty rash that's become one big rash that mum and dad are saying it started on tummy, going all the way down the legs. If you can click again, please, Mozhy. What are your differentials for a child with a rash? Yeah. Any other differentials? Yeah, measles, chickenpox, HSP. Yeah, all the MMRs. Yeah. Yeah, ALL, always a really top one to rule out. Yeah, always have a high suspicion of meningococcal sepsis. Any other differentials? Yeah, brilliant. Okay, so if you click again, please, Mozhy. Yeah, contact dermatitis and eczema is a really important one. So the big information in this one, I thought it was quite topical given North London. They've not had the MMR vaccine. They were scared off by COVID, and this child would have been about 1 year old when COVID was happening. So timelines match up that parents were dissuaded from getting the MMR vaccine. And if you were a fun SP, you could have come up with the old humdinger that people believed MMR was associated with autism. That was quickly disproved, and that doctor struck off the register. But it's a classic OSCE station that we keep getting. So if you click through again, please, Mozhy. Yeah, just as Lauren said, you can consider measles, mumps, and rubella. The thing with measles is it has quite different presentation than mumps, for example. Mumps, they like to get you tend to get orchitis in young boys. They might get bilateral earache. And measles, they usually like to say it starts behind the ears and then it spreads down the trunk to the lower limbs. It starts off maculopapular and then it becomes a big confluent rash. You've also got things like sick disease, roseola infantum, which is more lacy, also associated with a high fever. People said chicken pox, very itchy though. This rash wasn't really itchy. Kid with a funky fever, want to think about a scarlet fever. So post-strep, that's why I ruled out the sore throat. And then more than 5 days of fever, Kawasaki. And as everyone said, really important to rule out any neck stiffness, any signs of sort of like photophobia. Are they getting really grumpy in lights? Is the rash non-blanching? Have they got tummy pain? You guys all did that. But I figured it was good to raise awareness of measles right now as it's on the rise in London. If you want to click again, Mozhy. Just a quick whiz through of measles. Make sure you isolate them. Don't send them to school. You need to notify somebody, and you can take saliva samples. So that's it for History 1. And then History 2. How do people find History 2? What were thoughts on History 2? No thoughts? Oh, come up with differentials, yeah? Okay, so this one was just me being mean. It's on the previous list of stations from Manchester, and it's a really good one actually to consider how you approach funky presentations in kids. So the history is that you've got a mum, dad, whoever, bringing in their 3-year-old who's already been given this vague diagnosis of like failure to thrive. They just were playing at nursery. They've started at nursery fine, but when they were running about, they just got out of path. They couldn't keep up with the other kids. That made mum and dad worry, so they went to the GP. GP met the child, said, "Oh, that doesn't look right to me either," made a referral to peds. So this one, if you got through the development in the early years a bit more, they've been being monitored since they were born for a funny sound that they had on their NIPE. So what could that be? Which heart defect might people be asymptomatic with? They might be fine with, that you tend to actively monitor and consider surgery. Associated with lots of like congenital defects and stuff as well. Yeah, a VSD. So a ventricular septal defect is a lot of active monitoring. Yeah, tetralogy of Fallot, you tend to get that more in the like neonatal period though, because they'll have TET spells where they go blue after lots of crying, and they might even stop breathing at points. So TOF less likely, but yeah, a VSD. So if you click through Mozhy, sorry, I didn't make this slide pretty. So when it comes to failure to thrive, if you click again, please. You can group it broadly into, are they not taking in enough nutrients? Or the ones that are taking in, are they not absorbing properly? Or are they not using them properly? Or do they just need far more? So this isn't really an MLA session. I took this again from teaching on pediatric surgery. But if you guys have a think, particularly in OSCEs, how you can ask questions that rule in or out these different conditions, then your differential list actually becomes massive, and your history taking is the best tool you have until you're in the obviously specialist peds world and the seniors have all the tests at their disposal. So just thought that was a good one to have a go at. It was a previous Manchester station where it was a child who came into failure to thrive due to congestive heart failure, which they tend to see with like exercise tolerance, generally tired. They might meet some of their milestones slower to meet others, but it's because they've got this underlying increased demand from their VSD that was heard at birth and they were actively monitored, but they seemed to be doing fine. And then they come in, and a GP said to me once he had this girl who was completely well otherwise, and he just noticed on like the follow-up appointment they did a few weeks later, she had a really big tummy. And it's because she had hepatomegaly. She'd got congestive heart failure backing up into her liver. And that was the only thing that helped them identify she had a heart defect. Otherwise, she didn't have a murmur. She was a pretty well kid. So always one to consider. But that's it for histories. I'm about 5 minutes behind, but in terms of whizzing through exams, that will take 2 ticks. So Mozhy, if we kind of click through these, this is just for you guys to look at in terms of other defects. So guide to examining kids. I know it's not obvious for everybody if you're not like a fan of kids. Knowing how to approach them is tricky, and I know people sometimes take too much time on it. Oh, cause of the vomiting, that can just be when they've like exercised a lot and they really can't tolerate exercise. Vomiting is just one of those things that can happen in children when they've kind of overdone their threshold. It's like normal vomit, and they just kind of bring it back up because they're just so tired and really struggling after exercising. It's one wacky way kids can present with heart failure. No problem. But yeah, this is just a general guide to examining kids that you guys can read over. Particularly, I know not everyone's confident examining children, but don't dwell on it too long. I know someone who missed half the neuro exam because they were too busy building rapport with the kid and their socks. So if you move on, please. APGAR score comes up a lot in your SBAR stations where they say this was their APGAR. So I've just put a little guide of what the scores mean and when you need to worry about them or not. And in terms of the NIPE, it's top to toe. It would take ages to go through. The main things to know is when you refer. if they've got no red reflex when you manage to opportunistically look in their eyes, if they have any new murmur, so this kid would have had a murmur, referred, assessed, monitored. Now we've fallen into heart failure territory, so now we might consider surgery. And then obviously your Barlow and Ortolani tests and any undescended testes by the second exam. First exam might just be physiologically slow, second, worry. Next one, please. Cardiovascular, this is just a summary of the murmurs. You guys can read over that. Increased work of breathing in children. The recessions are the really big one that are different from adults. The other stuff, like just being generally tachypneic, they might have wheeze, they might have stridor. That's quite adult as well, but it's the recessions in children because they have different mobility in their chest wall. That's the word. Moving on to the next one, please. And abdominal masses are quite different in children. You can have things like your intussusceptions. You can have a little mass from the donut of a pyloric stenosis. You can have a nephroblastoma. So that's one to consider. If you felt a mass in a child, what might you think it is? Hepatomegaly, you can get, again, from congestive heart failure. Check your hernia areas, anal patency, lymph nodes in the groin area, and consider if it might be appropriate to palpate for the testicles in a male child. I don't think I've seen that routinely done. It's what they've put in the booklet at Manchester. I don't think it's routinely done. And then for the neuro, it's basically the same. Distraction becomes more important. And add in the Gowers test. It's basically if they need to roll themselves onto their front to get up, then you worry that they've got some kind of proximal weakness of their muscles that they can't initiate the standing up movements. And then last one, P-gals. So it's literally the same as the adult. It's just be really clear on your instructions. Show, don't tell. So ear to shoulder is kind of confusing to a kid. So just go, can you go like this? Can you go like that? And then the TMJ, inserting the 3 fingers. If I was a kid, I'd be kind of hesitant to do that. So just show them that it's fine. But otherwise, yeah, your gait, arms, legs, spine assessment is pretty much the same as adults. And add in those little nuances of maybe pop them on mum and dad's knee and introduce a toy if they're quite young. But that is it from me. That's very much stuff that I've just compiled together as a fellow final year and isn't too niche, I hope. I'm sorry it's not an F1 as usual, guys. As I say, lots of rota issues. And Charlotte is still here despite illness, and Mozhy's still here despite massive understaffing on her ward all day. So thank you for your patience.
Get started. So we are moving on from history taking to a bit of communication skills, because PEDS is all about communication with parents. People care much more about their children than they do themselves, so typically can be a lot more anxious. We've got 2 communication skills stations to practice. We've got a 2-year-old child who's had a febrile convulsion, and his mum would like to have a chat with you. And I believe we have a little 5-year-old boy with scarlet fever and a bit of a kind of non-blanching rash due to mechanical coughing. So we'll go into breakout rooms straight away, keep things practical. And you guys can take 6 minutes per station, and a quick minute for feedback. Welcome back, guys.
Welcome back, everyone. Before we get going with the next bit, Mozhy, we had like 5 of us practicing together, and our anxious mum was worried about the non-blanching nature of the rash. How do you help?
So the prompt, I'm sorry if that wasn't very clear. This kid is coughing loads, very violently, and they're getting a rash around their neck and their chest from coughing loads. So it's a mechanical non-blanching rash from little capillaries bursting from the force of their coughing. You reassure an anxious mum that it's not meningitis by first of all explaining the mechanism of a rash like that, but also saying meningitis has these symptoms. Does your child have any of these symptoms? No. We don't suspect that it's meningitis at this stage. We have a diagnosis and an explanation as to what the rash is, given the history of the coughing. And then if you really want to cover your back, you can safety net and say, if they develop any of these symptoms, any meningism, like neck stiffness, photophobia, vomiting, headache, anything like that, then we can please reattend, or, you know, please seek medical attention, and we can revisit and reinvestigate as needed. At this stage, there are no symptoms of meningitis. There's lots of causes of a non-blanching rash. We tell parents this because we want a really low threshold for people bringing their kids in for meningitis, but it's not meningitis, basically, is how I would say. No, adults, I did a Muay Thai class in Thailand and worked out so hard. I was getting like little petechiae around my eyes, like, you know, if anyone who's doing any really like violent, rigorous actions can cough. Obviously, kids are small and so more prone to getting little petechiae from mechanical coughs, but you will meet adults also who get it like around their eyes from workout classes, you know, like it just happens. So yeah. That another question.
Amazing, thanks, Queen. Yeah, Lawrence, you're so right. No Muay Thai.
It was great. I loved it. I would recommend it. Fine. Any other questions from anyone before? Well, we can go through things now. Let me find my slides because I've lost them. 1 second. Where are we? I believe it's crashed, so give me a second, guys. Here we go. And going back to where we were. Here we go. So, febrile convulsions. NHS website has a great little, any condition that I'm not really sure how to explain this, the NHS website generally will have you covered. Essentially, the summary is kids have developing immune systems that are not as mature as adults, which means that when we get infections, or when kids get infections and they get a very quick fever, they can be prone to having seizures. If this has happened once, there is a chance that if they were to get a fever quickly again, it could happen again. However, they are at no increased risk of epilepsy. And that's the kind of headline of no increased risk of epilepsy, but potentially risk of recurrent febrile convulsions. The important thing to do is, first of all, reassure, and then counsel on kind of what to do if the child has another seizure. And that is kind of protect their head, don't try to keep them still, time the seizure. If it's more than 5 minutes, urgently seek medical attention. And then to just be aware that there's no way to prevent them, basically. If your child gets ill and they get a big fever, they may have another one. But they're not generally dangerous. So, any questions on the febrile seizures station? I can't see the chat, sorry. So if there is, could someone verbalize it to me?
Someone asked about the other one, just like, is the cough because they're coughing so much? Does it happen in other conditions where you have a lot of coughing?
Yeah, so any violent coughing can cause a bit of petechiae around the chest. It's not special to scarlet fever or anything. It's just one of those things. It's like a mechanical non-blanching rash, which if you Google will come up as well. And again, anyone can get it. It's just little burst capillaries from coughing too hard. Usually it's like a few tiny dots, but parents notice it and get worried sometimes. Any other questions about this one? Sorry, go on.
Sorry, I had a question about the other one, the scarlet fever. Sorry.
Oh, the scarlet fever. Yeah.
No, wait. hold on, no, not scarlet fever, the febrile
The
seizure. I'm
febrile
so sorry.
That's fine.
So if they ask, like, how do you know it's not epilepsy? What do you say? Is it because we know they had a seizure because their temperature was really high?
So if a child, you can say to them, is getting unwell, they're getting as high a temperature as your child has got from the symptoms that you will have elicited from them, and they've had a seizure. This is a relatively common thing that happens, and it's a known diagnosis of febrile convulsions. Probably they will have been investigated for other things as well to rule out, meningitis potentially with an LP, whatever. But just in the context of, at the moment, we don't have enough information to say your child has or doesn't have epilepsy. We know they've had a high fever, they've had a seizure. That's a commonly seen phenomenon of febrile convulsions. If in future they're having more seizures or you're worried in other ways, then obviously they need to reattend and that needs to be further explored with neurology. But it's like a known diagnosis, febrile convulsions. That makes sense. Any other questions?
Doesn't look like it. That was fab.
Fab. Let's move on. We're going to work through an A-E together, if that's okay. And then we will do a practice A-E. So the way I'll run it is just, we have a case. I'll ask you guys what you would do for A, B, whatever, and then kind of take it from there. So you're an F2 covering pediatric admissions. We've got a 5-year-old girl. She's brought in by her father. She's been feverish, sleepy, and she's been breathing fast today. Please do an A-E and describe kind of what you would do as you go along. And we're not going to take a history from this patient, and your prompt will clarify you don't need to take a history. She's just had a high fever 2 days, cough, and she's not eating breakfast today. So let's start with airway. What are we looking out for? Any thoughts? I still can't see the chat if there is any thoughts. If somebody could let me know.
Someone says, is airway patent, noisy breathing? Is she talking? Is she responding? Stridor, wheeze, any extra sounds, any obvious obstructions?
Amazing. So we're just seeing, can the patient talk and full sentences? Great, airway patent. If not, can we hear any kind of grunting, snoring, any gurgling, wheeze, stridor, like you guys mentioned? And in this case, airways patent, no stridor, no obstruction, able to speak in sentences. We just noticed that the mouth is a bit dry. So let's move on to breathing. What are we going for? And again, I can't see. So Charlotte, I don't know if you're able to comment what people are saying. Or have we lost Charlotte?
I can read out what
I can read. Oh,
Thanks, guys.
So we've got respirate, oxygen saturation, chest inspection, tracheal deviation, and then also auscultation and percussion.
Amazing. I always like
also
to start
air
with
entry as well.
Perfect. Yep. So respirate, we've got 52. So a bit tachypneic. Oxygen saturation's 90% on room air. It's going to give the answer away. basically, you want your observations as the first thing you do, and you just address your observations. So if oxygen's low, just stick them on high flow, 15 liters, non-rebreathe mask. We've got some subcostal and intercostal recessions, bit of nasal flaring, bit of audible grunt, so increased work of breathing, asymmetrical chest expansion to the right, reduced, you have a listen to the chest, reduced air entry in the right low lobe, sorry, some crackles and a bit of wheeze and a bit of cough. So we're going to get that oxygen out of the way early. If they are wheezy, we might consider some nebulizers, so salbutamol, kind of a low dose to trial if that helps. And then any child with increased work of breathing, at this point, I would say I'm going to escalate to a senior colleague while I finish my A to E, because as an F1 or F2, like, you don't want to be dealing with this by yourself. Circulation, what are we on to next?
People said heart rate, blood pressure, heart sounds, CRT, temperature, rhythm.
Amazing. Cool. Yes. So heart rate 162 beats per minute. Blood pressure 88/54. Temperature, I like asking temperature in my circulation because when I take bloods, I'd like to know if I'm going to be taking blood cultures or not. Some people do it in D, some people do it in E, do it wherever you like. We're going to start peripherally, so reduced cap refill time, or prolonged, sorry. Cool peripheries, weak pulses, mottled skin. We're kind of working from the hands to the arms up. We already know from looking at the mouth that they've got dry mucous membranes. We're going to get some IV access from this patient. We're going to want some bloods. Given that blood pressure is low and they're a bit tachy, we can think about small fluid bolus. We obviously want to be cautious in kids and what volume we give, so resuscitation kind of volumes. Don't worry about that too much for CCAs. You can just say, I want to give an IV fluid bolus. And then given that they're pyrexial, you might consider some paracetamol, and then they seem to have some kind of infection going on. So you might think about some antibiotics, but that you can say you'd kind of consider is always a nice word to use. Yeah, moving on to disability.
We've got AVPU, PAL, BM.
Amazing. So responding to voice, we can also look to do a GCS, a formal GCS if appropriate. People's equal and reactive to light. Glucose, don't ever forget glucose is 3.8, so like a bit low, but okay. And she's complaining of right-sided chest pain when she's awake. And lastly, exposure, what are we doing?
Full exposure, looking for rashes, bruising, jaundice, bleeding, abdo exam, skin exam, trauma, swelling.
Amazing. Very thorough, guys. I love to see it. So we don't have any rashes, no petechiae, no signs of trauma. We just notice again this unilateral breathing, abdomen soft non-tender, no meningism. You might think about a neuro exam and exposure as well, now that you've got more time to kind of do everything else. But yeah, that is our A2E. We've given some oxygen to this patient. We've given some fluids, some antipyretic seals. We've thought about antibiotics, stabilized them. Having done that, what do we think is going on with them, and what do we think comes next? Are we worried about this patient?
So people said sepsis, sepsis 6, worried.
Oh.
Yes, and chest infection.
Amazing. So this is likely sepsis. And what's pointing to sepsis for you guys?
Low BP, tachy, high temp, unwell, mottled skin, hemodynamically unstable, and temperature.
Yeah, amazing. And I've included this as a case of pneumonia, just to say that like kids can get pneumonia too, basically. I always feel like the pneumonia suspect is 80-year-old lady Mary, but it can be as straightforward as a chest infection for kids as well. So yeah, sepsis 6, we're getting early escalation. We might involve anesthetics if we're worried at any point about kind of airway stuff, which at the moment not. We're going to want to re-review this patient, especially because we've given a few interventions to see if they've helped stabilize them. And yeah, kind of take it from there, I believe. Any questions about that one? And if not, we will. Sorry, go ahead.
I just wondered, so we can get a child as our A2E station?
I think it's unlikely. I think that because they're dummies, they're adult dummies, that they'll probably just give you an adult A2E. But it's if you do, there's nothing different about your approach really to doing an A2E. You're still just working from A2E and doing the same stuff. So I think it's less likely. I think it's not impossible, but it is less likely, would be my general advice there. We've got.
I was just wondering,
Sorry.
who do we actually escalate to in terms of, is it like the pediatric reg? Like who do we?
Yeah, good question. So your first point of call would be your pediatric registrar. If you're worried this patient's really, really unwell, you can say you would put out a medical emergency call, which will bring like ITU, anesthetics, basically everyone. If it's an airway issue, then anesthetics. If it's a breathing issue, you can think about a pediatric respiratory consultant, or peds respiratory reg on call, whoever that might be. I think your first point of call being the pediatric reg on call. Start there. And then you can always say, I would consider ITU involvement. I would consider, further involvement depending on the issue.
Okay, thank you.
No worries.
Go
ahead.
Sorry, I just wanted to ask if you had any resources to help me remember the like heart rates and breathing rates that are normal for kids, because it's different at different ages and I get really confused.
I think it's tricky. I can look to see if I can find a good resource to send out when I send out the slides, and get back to you if that's okay.
Thank you.
No worries. So we have a second A2E station, which I was hoping you guys could go into breakout rooms for. So one person does the A2E, and then we'll send kind of the A2E for the other person to read out, and then we'll work through kind of differentials and next steps together, if that's all right. So if we can go into breakout rooms. How did people find that? I still can't see comments. If somebody shouts them at me, that would be very helpful.
There's a good few thumbs up.
Great, somebody is clapping, which I love to see. So we have a 14-year-old girl. She's come in, she's been vomiting all day, she's feeling very drowsy. We're doing an A2E, she's refusing food and drink, and she's a bit confused. Airway, normal voice, no stridor, patent, nothing to do in airway. Talking in sentences, move on. Breathing, so bit tachypneic, but oxygen saturation's okay. You can say at this stage, I wouldn't consider giving supplemental oxygen. However, I will continue to reassess given that they're tachypneic, and yeah, if needed, can put them on non-rebreathe. So even if SATs are okay, you can say that to say, I know that if my patient's SATs are low, they need oxygen. That's box ticked. If you'd have asked for respiratory effort or what their breathing pattern was like, you might have picked up that they've got cuspal respirations. Chest was clear, no wheeze. Otherwise, breathing was pretty uneventful. If we move on to circulation, they were tachycardic and hypotensive, so it would be reasonable to give some fluid at that point. Again, cautious IV fluid bolus, see if the blood pressure is responding. Would be reasonable. Temperature not raised, capillary refill time reduced, and peripherally a bit cold, and they seem a bit dry if you kind of do a quick hydration status. So you can say, like, do they have moist mucous membranes? And you can even look for a JVP if you want to give fluids and you want to make sure you're not going to overload them. Less appropriate for peds, I guess, but can be helpful in adults. So we've given some IV fluids. Move on to disability, and at this point we're thinking, like, I know this is an A2E, I know something's going wrong with this patient, I don't know what it is. Don't ever forget glucose. The glucose is 32 in a young patient who hasn't previously been diagnosed with anything. At this point, if a diagnosis isn't popping out to you, but the only thing you're thinking is that's a really high glucose, don't worry. Generally, if you're getting glucose, helpful to get ketones, so we know if they're in ketoacidosis, and in this case, ketones would have been raised, and nothing else on kind of exposure to talk about particularly. What are people thinking for what's going on with this patient? I still can't see your comments, guys. Sorry. Sorry, go ahead.
DKA?
Nice. Yes. Very good. I think DKA can be such a vague presentation, and it's really stressful feeling like you're not picking it up. But if you follow the A2E algorithm, and like the only thing that comes to your mind is they're hyperglycemic, so I'm going to manage that. They're hypotensive and dry, so I'm going to give them some fluids. Like, that's enough kind of thing, so don't worry too much. But yes, DKA, always good to think about other things. So if they're vomiting lots, gastroenteritis, we might think about sending cultures off. Sepsis, even though the temperature is normal, you can say, you know, not everyone who is septic has pyrexia, so just to keep it in the back of your minds. And then kind of further down on our differentials list, I've put surgical abdomen, but the abdomen is soft and non-peritonitic. And then number 5, to keep things open to imagination, whatever you like. Good to just have some backup differentials to show that you're keeping a wide net. In terms of management, the first step of management for DKA is IV fluids. So if in circulation with their low blood pressure, you've started them on fluids, then you're halfway there, you've done the first step. That's going to help to dilute the glucose in their blood. And then we want to think about an insulin infusion, generally a fixed rate infusion that then will get switched to a variable rate. You can say, I would commence the DKA protocol if you've identified that it's DKA. We obviously want to monitor blood glucose and ketones closely. We want to do neuro observations. In these patients, we would also do a VBG, and that's because insulin can affect potassium. It's one of the treatments for hyperkalemia, and so we're expecting a crash in potassium. So we need regular VBGs, so we know what the potassium's doing, which will guide our potassium replacement in our IV fluid resuscitation as well. Does that make sense? Any questions? Fab. If no questions, we will move on. It is 8 o'clock, so if anyone would like to leave, you're obviously welcome to.
We can also pitch to the crowd maybe, because we've got good data interpretation stuff coming, guys, which we're happy to sit and go through. But equally, it is also available in the slides. So it's up to people what you want to do, because Mozhy and I can sit and go through it, and then it will also be on YouTube. Main thing is just please do the feedback form.
Yeah, please.
Yes, people want to go through it. Okay, nice. We've got enthusiastic attendees. Let's go for it.
Well,
The
I'll
people
try and
love
keep
you, Mozhy.
Okay, cool. We will work through this not too rapidly because I want it to be helpful, but we'll keep it moving. If you have any questions or would like me to slow down, please tell me to do so. We've got a 14-year-old boy brought to clinic because he is much smaller than his classmates and hasn't started puberty. He's healthy, good energy levels, eating well, engaging in hobbies, generally doing all right, just a bit small. Family history, his dad had his growth spurt at about 15 years old, 16 years old, and no other kind of history. He's got basically no symptoms of anything, just that he hasn't started puberty yet. So what are we doing for this guy? What's our first step?
Take measurements of height and weight.
Yes, exactly. First, I've decided to do bloods, but it's much more reasonable to do some measurements. So I've got my slides the wrong way around. Sorry, guys. Let's go one more. So he's got a growth chart. So we're going to have a look at his growth chart and see what that is doing. At the moment, he's around kind of 38 kilos and kind of 147, 48-ish centimeters tall. His BMI has stayed stable. So even though he's not really getting much taller and he's not getting that much heavier, he is stable BMI, which is important, and we'll talk about why. So having done that, we're going to do some bloods and other investigations. Have a look at this and then let me know your thoughts. Would anyone like to have a crack at kind of talking through investigations like an OSCE?
I can try.
Go for it.
I'm just going to be talking out loud, to be fair. Hemoglobin is fine. Ferritin is fine. TSH is in range, and so is 3T4. He's showing us prepubertal for sex hormones. IGF-1 is low normal, and his bone age is low. So it just looks like he's pre-puberty. he could have delayed puberty. There's not a growth hormone, is there?
Let's say growth hormones like low normal as well.
I think like then it would just be like slightly delayed puberty, but you wouldn't necessarily think that there's a reason it won't happen.
Yeah.
If it's
So are you
low
worried
normal,
about it?
no, it's more his self-esteem that's the problem, probably.
And
Like,
why is it that you're saying it's probably just pubertal? We're not concerned about endocrine issues.
nothing's like hugely out of whack. It's not like his hormones are all over the place. They're all like low normal. Yeah, it doesn't seem like anything's like horribly mismatched. If he doesn't have like an absence of growth hormone and those things, it's just less worrying.
And how about his X-ray? Any thoughts on his bone age X-ray? Anyone? He doesn't. Yeah. No, go for it if you know.
Someone just said that it's lower than his chronological age.
Mm-hmm. Does that mean anything to anyone? Is that worrying or reassuring?
Isn't it reassuring? Because it's kind of like, again, aligned with like the pre-pubertal kind of thing.
Yeah, amazing. Well done, guys. So we've already gone through the growth chart, which is showing some vaulted height and weight. We also examined him. This is in the complete wrong order. I'm sorry, guys. And he was fine. So everybody's right. Our top differential is that this is just constitutional delay. Stable weight, stable BMI, hormone profile is suggesting pre-pubertal. The delayed bone age is actually saying this guy's still got a lot of growing to do. So the short stature is saying, yeah, he's just delayed, but his bones are just not there yet. He's still growing. And otherwise, he's well and no kind of family history of any endocrine issues. We would think about other differentials that might be more serious and need addressing. So growth hormone deficiency. But generally with growth hormone deficiency, bone age would be normal, which is to say like you're not delayed, you're deficient in growth hormone, so you're not growing as much. Hypothyroidism is another one that we'd expect kind of symptoms of hypothyroidism to come along with that. So the fatigue, cold intolerance, constipation, and you'd see it in the thyroid function tests, which were normal as well. But yeah, so in this case, generally it's just reassurance. You mentioned about psychological distress. So if they do have psychological distress and they're getting bullied at school and things, we can think of giving a short course of low dose testosterone. But otherwise, eventually they will go through puberty and kind of catch up. And then obviously we always monitor when it comes to growth to make sure that things continue to stay on track, because if things changed, then that needs revisiting. Any questions about that one? And if not, I will move on to the second one. So we have a 9-year-old boy who's come to the emergency department with a 3-week history of increasing tiredness, pale skin, and bruising on his legs. His parents report that he's been more breathless on exertion, and he's had intermittent low-grade fevers, no recent travel or known infections, and no significant past medical history. He's just had some nosebleeds over the past week. He appears pale, tired looking. He's got lots of bruises, bit of organomegaly. We've got his observations there. So slightly tachycardic, slightly tachypneic, low-grade fever, like it says, and then bit of kind of dropping weight over the past year on growth chart. Any thoughts on this patient? Are we worried about them, and why so far?
Someone said ALL.
Yeah, nice. Why ALL?
I can answer. I'm just aware I've been talking a lot.
No, please go ahead.
He's got these symptoms. It's really indicative of cancer with the fevers, the bruising, epistaxis, and his history of weight loss. And all of it together is just really concerning.
Yeah, nice. Let's go to the next page. So we have some bloods here. We've got low hemoglobin of 68, raised white cell count 32, neutrophils low 0.4, platelets 32 also low. We've got blood film results and the rest of our bloods over here as well. So raised LDH, raised uric acid, prolonged prothrombin time, and low fibrinogen. What picture is this showing now in terms of not necessarily diagnosis, but just overall observations?
Our rods, aren't they like pathogenomic for ALL?
ALL? Yeah.
I think you can
So-
see it in, can you see it in AML as well?
Yeah. It's actually more kind of associated, I believe, with AML. And kind of, yeah, I would say more pathognomic for AML, but yeah, can't rule out ALL at this stage either. So given the hour odds, our top differential would actually be AML. And you can get young kids with AML. I know ALL is like the stereotypical hematological malignancy you see in kids, but it can be also AML. So just be wary that if you get a hematological malignancy, you don't just box it into ALL without considering other differentials as well. So ALL is also a perfectly reasonable differential. And then we can think about aplastic anemia because they had kind of low hemoglobin, low platelets, and low neutrophils. So whether there's been a parvovirus that's caused aplastic anemia, either way, we are worried about this child. We need them urgently to be reviewed by a specialist. This is above our pay grade, but it needs to be addressed quickly. Any questions? That was, again, a bit of a quick one, just on heme malignancies.
What setting was this meant to be in?
That's a good question. The emergency department. If this was GP and you didn't have like bloods, then they need urgent FBC. I can't remember whether it's within 24 hours or 48 hours, but you would advise them to attend ED for a blood test because the GP bloods wouldn't come back in time. Cool. So we did have one more station. We won't do it this evening. But it's a difficult communication station that is worth kind of thinking about. So it's to do with non-accidental injury and safeguarding. This was going to be a station about an actually very understanding dad, because I didn't want to be mean and give you another kind of anxious parent or difficult parent. So just helpful to know when it comes to kind of children who are vulnerable, which is anyone under 18, a referral to safeguarding or involvement of police or anything like that does not require their consent or the legal guardian's consent. if you are concerned, you have a low threshold, you raise it. But it is important to, where possible and safe, communicate that a safeguarding referral is being made. We're not accusing anyone of anything. You know, you might raise to a parent that we're raising a safeguarding referral and the parent actually has no idea what's going on, and there may be another kind of caregiver in that child's life who may be involved in an incident. And so it's very non-judgmental. And the way you would communicate it is to say, we have no way of filtering through ourselves as people what is a serious case and what isn't. So we have certain thresholds that if the child hits that threshold or has kind of presented in a certain way, we would always refer regardless of whether we're suspicious or not. And that allows for a kind of unbiased investigation. It's there to keep everyone safe. Given that children are vulnerable, it's our responsibility to do that. And there's a list of kind of reasons you might refer. So injuries inconsistent with history, multiple injuries, recurrent ED admissions, unexplained bruising, especially on kind of soft parts of the body as opposed to bony, fearful behavior, failure to thrive, poor hygiene, and there's a lot more. It would be quite a harsh station, I think, to give, but they could give it as a difficult communications, and you have to communicate why you're doing a safeguarding referral. So I just thought I'd put a little bit about that in. And then quickly just about consent in children, which I'm sure you guys know back to front now. So children 16 and over can consent to treatment as if they were an adult. If they decline treatment, then potentially the court can overrule them depending on how kind of important it is. Sorry, it's getting late in the evening. Children under 16 kind of run off Gillick competency. So are they mature enough? Are they intelligent enough? And do they have capacity to consent? And that would be kind of the same way of testing capacity. So are they able to understand? Are they able to retain, weigh up and communicate a decision? Their right to refusing treatment, however, can be overruled by a parent or the court. And again, you know, that's because of the kind of unwise decision thing. And then just a quick thing about Fraser guidelines. So it's a subsection of Gillick law that's to say that you can provide contraceptive to a young person who is sexually active under these circumstances. And so you may get a station, for example, that is a parent who's come in and says, I know that my daughter's come to the GP and I'm pretty sure she's got herself a boyfriend. You need to tell me, did you give her contraceptive or not? And it's up to you to say, actually, we can't disclose that. That's kind of, you know, if we were concerned, if there was safeguarding issues. So if we were concerned there was an older partner, then we would let you know. But otherwise, we can't disclose that information to you, is kind of the approach you need to take. And I believe we're there. Thanks for sticking with us, guys. Any questions about today at all?
You were brilliant as always, Mozhy. I can't believe you did all that still in your scrubs after the longest day ever.
And you were brilliant. Thank you very much, Charlotte, for filling